Good morning to all of you from Boston, and again, thank you for joining us in this educational initiative that has been endorsed by IFFS. In this COVID-19 in reproductive medicine series that we are doing through 2 months now, as you know, we have been going from the initial experiences of the pandemic in China, Italy, and then to learn what is in IVF, also the endometrium, miscarriage, and today we will just go to the newborn, and finally next week we will finish this series. Next week I shall remind you that Dr. Roberto Romero will be with us, and I think this will be very interesting for the obstetricians joining us in these webinars, because he will be focused on the obstetric care in COVID-19 patients and what is known about the vertical transmission of the virus. I want to inform you, well, all of the webinars so far, you can just access them to this link that you have beneath, and it will be, you can download it and you can just listen and see the webinars wherever you feel comfortable to do it. After this series finish, we are going to continue with this educational initiative from Igenomix Foundation, and the new program, the new series is going to be named as Reproductive Medicine, What is New? And we will start in June, and we will try to go through the main topics that it will be new now after the pandemic, after these months that we have been working and people is working in their own labs without getting to the clinics. And the topics will be about the cell-free DNA analysis by Carmen Rubio, then what is new about mosaicism, embryo mosaicism by Dr. Antonio Capalvo, then the maternal embryonic communication by Felipe Vilella, and what is new about the endometrial bacteriome and virome by Dr. Inmaculada Moreno. And I will finalize the series, just wrapping up all the knowledge that we will have at this moment in July about the pandemic and what could be the impact in reproductive medicine, and what is next about COVID-free 90 clinics. If I can get just the next slide. So without any more information to add, it is my pleasure to introduce you to Professor Alexis Davis from Stanford University. She's a pediatrician. She's associate professor at the Department of Pediatrics and Neonatal Medicine at the Stanford University and medical director of the Neonatal Intensive Care Unit at Lucille Packard Children's Hospital at the Stanford. She's going to enlighten us about what is known about the COVID-19 pandemic and the newborn and in the pediatric care and what is new about this topic. For us, reproductive endocrinologists, I think that we need to know what is after what we are going to have, and I think that this lecture will be very interesting for all of us. So without further ado, please, Dr. Davis, the floor is yours.
Good morning or good afternoon or good evening to all of you, and thank you to the organizers for inviting me to give this talk. Knowing that the audience here is largely reproductive medicine, I'm hopeful that the information that I'm going to convey will help you answer questions from your patients as they move through their reproductive journey, understanding what this current pandemic might mean for when they finally get to the time of delivery, and if they have any complications with their delivery. This information that really is not reflective of my own work, but rather that of a real team, a multidisciplinary team we have here at Stanford, as we worked through our operations and workflows in response to this emerging pandemic. First, I'll just start with a disclosure. I am on a scientific advisory board for Lancino, but I'm not going to have any relevant discussion in that regard today. And the outline will just go over here. I'm going to talk a little bit about the screening and management of pregnant mothers in labor and delivery, our isolation and triage considerations, management of the newborn infant in the newborn nursery, as well as in the NICU. And then talk about what we know, but perhaps more importantly, what we don't know yet about infections in newborns. And I put in parentheses surge planning if we have time today. I can just share some of the work of our disaster planning committee as it relates to anticipated surges as a result of this pandemic. So first, what do we know about the novel coronavirus? Everybody is inundated with information about it, but just as a brief review, COVID-19, which seems to be the lay term that we use, really is the symptomatic infection that results from the novel SARS-CoV-2 virus. Typically, coronavirus is thought of as a droplet pathogen similar to influenza, but initially it was classified as a novel pathogen requiring higher precautions for PPE as a result of what seemed to be a very rapidly spreading and concerning pandemic, we think beginning in Asia. However, although it's a droplet pathogen, it's also known, and this was some work published recently in the New England Journal, in the setting of airborne generating procedures, droplets could actually be airborne for at least 3 hours. And I think that's why we've treated this pathogen with extreme caution. But at the same time, I think the questions that we've had as we've entered into this pandemic is, can we make some parallel associations for viruses with which we've already had some experience, such as MERS, the original SARS-CoV-1, or even influenza, which, as we know, has seasonal waves and we deal with much more frequently. So I just want to go over the basic tenets of intrapartum and perinatal care. We are all very fortunate that the vast majority of our mother-infant dyads are very healthy. But those of us in obstetric and neonatal medicine also know that the transition from a routine delivery to a crisis can happen very, very rapidly. Some examples of this would be a setting where there is a sudden maternal decompensation, such as an amniotic fluid embolus requiring an emergency cesarean and of the mother, and also that transition after the baby's born. Whereas the delivery might have seemed routine, we can also have an unexpected need for neonatal resuscitation. And with this, aerosol generating procedures are really the routine to manage these crises. And as a result, if the mom is infected, poses a risk for healthcare workers and who are in attendance at deliveries. And it really underscores the importance of knowing the mother's infectious status at the time of delivery. So this slide is just going to kind of go over our evolution in response to the COVID-19 pandemic. We started out in late February and early March, really trying to use our best judgment, again, borrowing our knowledge from other viruses such as influenza, and trying to draw from our own infectious disease expert opinions. And at that time, we had limited testing capacity with fairly strict predefined testing criteria, as well as a long turnaround time in getting those results. And as a result, we had the number of PUIs, or persons under investigation, far greater than true positive, which really created a lot of alarm and precautions in our delivery room. We moved into an era where we had more liberalized testing capacity, but still somewhat of a long turnaround time. And again, still having maybe the types of scenarios where we had PUIs in greater frequency to the actual true positives. We're now in an era where we are doing universal testing of mothers with testing that can be done with rapid turnaround time, such that we have fairly good confidence about a mom's infectious status at the time of delivery. In fact, we're already operationalizing, many places are operationalizing having moms be tested in the outpatient setting if there's a known induction of labor date or scheduled cesarean section. And just this week, I believe ACOG issued guidance essentially affirming a recommendation for universal testing of pregnant moms. There are some delivery room considerations for moms who are either asymptomatic and infected or symptomatic. Typically, the recommendation is for those moms to be in a negative pressure airborne isolation room, single patient rooms can be considered, and we'll sort of talk about the questions around that. I think what's really interesting in the setting of labor and delivery is this labor support person, typically the father, effectively is considered a direct contact. Presumably they're cohabitating and in close communications, and the question is whether they should be considered presumed positive. That's the stance many places are taking. And to limit exposure to the healthcare environment and other people in the hospital, some places are having directives that this labor support person really needs to stay kind of sheltered in place, essentially with mom in her labor and delivery room. I think there's a lot of controversy about whether stage 2 labor is considered an airborne generating procedure. I don't believe ACOG has come out to issue this, but I think there's a lot of questions about that. There is a publication in the American Journal of Perinatology that effectively recommends using the highest PPE precautions, I think just out of an abundance of caution. And let's see next. And so when it comes to, again, this potential for crisis mode, there's a recommendation from a PPE standpoint for if a mother requires intubation, using the CAPR or PAPR devices, or at the very least an N95 if intubation is required. But certainly PPE policies are going to vary by institution depending on their equipment availability. There are a few ongoing unanswered controversies, and that's what is the safety of delayed cord clamping in the setting of an infected mother, as well as what is considered to be routine, standard, and if anything, developmentally ideal practice of having the baby be skin to skin immediately after birth. So there was a publication last month issued in the American Journal of Perinatology, and this was an international assembly of authors from people in Italy and Spain, which, as we know, were some of the hardest hit areas, as well as people in the United States. Anoop Katharia, the second to last author, is an expert trialist in delayed cord clamping. But I'd also like to highlight that this publication really reflects kind of expert opinion and not necessarily rigorous evidence-based recommendations. In this article that I'll refer you guys to, there are some really nice graphics put out by the senior author. He's a master medical illustrator. This really kind of is a schematic about the delivery room. I'm just going to highlight a few things that are different between a typical delivery room and a delivery room for a mom who is infected. And that's really using goggles, probably beyond the usual face shield that is recommended during delivery. And that's because of concerns about infectious risk with mucous membranes. So goggles or really significant eye protection are recommended. What's interesting about this schematic is their proposal that the partner, the labor support person, be present really just virtually. I think practically speaking, this is really challenging to implement or enforce, as obviously the birth of a child is a really memorable moment in anyone's life. They also propose with the green square source containment by having the mom wear a mask during labor. I will share that our OBs learned during the H1N1 pandemic that stage 2 labor and a mask are somewhat mutually exclusive, at the very least highly unpopular and difficult to ask a mom to do, but that's one consideration for source containment. And then lastly, in this publication, they recommend no skin-to-skin contact, but perhaps achieving delayed cord clamping by holding the baby away from the mom before cutting the cord. Then we move on to delivery room considerations from the perspective of the pediatrics team. And the questions that we have as we enter into these delivery rooms is, what are the risks of vertical transmission and having this baby be potentially infected? In early March, as we were developing our policies, there was very little data out. There was a publication about 10 infants born to 9 moms. The babies all tested negative. There was an additional case report in the Emerging Infectious Disease Journal, a Lancet article, which many people refer to, where they systematically tested the amniotic fluid, cord blood, and breast milk of moms, found no virus in any of those specimens. And at the time we were developing this, there was also rumors swirling around from our national pediatric infectious disease experts about a paper that was in review, eventually published in JAMA Peds, that among 33 infants born in Wuhan to COVID-19 mothers, 3 actually tested positive. So that really kind of raised the question about whether these babies are at risk for vertical transmission. And therefore, what is the risk to our healthcare workers? Despite the information in that unpublished report, again, borrowing what we knew from other viruses, we really do think that the risk of the newborn infant being infected is still quite low. Furthermore, we also feel it's felt in borrowing from how we manage infants infected with tuberculosis, which is a highly transmissible airborne pathogen. Newborns are really thought to not spontaneously generate aerosolized droplets on their own, meaning when they cough, they are not able to aerosolize to any significant degree or radius around them. However, in the setting of airborne generating procedures, such as those which occur during neonatal resuscitation, does that potentially pose a risk? So I think the way we would sum it up is it's low risk, but does that really equate to zero risk? And how do we conduct ourselves as a result? So where we came around was that those who were considered PUIs or positive, the baby is presumed a PUI or positive until known otherwise. As I said earlier, the labor support person is considered a direct contact, and therefore any delivery of an infected mom has a potential to be a risk to healthcare workers. We also have to approach it, as we said, the transition from healthy to crisis can be very quick. Any delivery has a potential to need resuscitation for the infant, and all of the hallmarks of neonatal resuscitation are those of airborne generating procedures such as positive pressure ventilation, CPAP, or even intubation. And so this is just a summary of some of the modifications we've made in response to having moms who are infected with the SARS-CoV-2 virus. We are a teaching institution. However, for these particular deliveries, we really are limiting those in attendance to the minimum necessary personnel. When these moms have other pregnancy complications requiring prenatal consultation, we're utilizing telehealth or just phone consults whenever we can so that we do not enter that mom's room until the time at which it's absolutely necessary. For deliveries that are considered low risk where a team wouldn't otherwise be called, we're still alerting our team because of the time that it's going to take to don PPE, such as an N95, and to make sure it fits well, or to don the proper protective eyewear. We're responding by really just hanging out outside the delivery room and waiting for our call sign to know whether we need to come in or not. We're also adding on, you can see with this red arrow, a respiratory filter to our resuscitation apparatus to try and create a closed circuit, again, as a measure of precaution against the airborne generating procedures that are essential to newborn resuscitation. And again, I mentioned there's a lot of controversy. We still don't have the answers, and I still have another meeting tomorrow about it to discuss it with my group about what kind of stance we have as it relates to skin-to-skin contact and breastfeeding in the delivery room. Again, from that publication I noted earlier, this is a schematic with respect to the delivery room personnel. The only thing I'm going to highlight here, in addition to all the PPE that's being used, is a recommendation that there be a physical barrier between the mom and the infant resuscitation bed, as well as some modifications for the delivery room resuscitation bed that is used. Typically, in most delivery rooms, an open radiant warmer is what is preferred, because then there's easy access around the bed to give the infant whatever help is required. But in this case, what we're doing is we're bringing in sort of dual function beds that can function as a radiant warmer, but can also close up the sides and the top to, basically encapsulate the baby in preparation for transport to the NICU or the newborn nursery. And so really, we think that the risk of vertical transmission is low, but the bigger question is the risk of horizontal transmission of this virus from mom to baby. We talked a little bit again about the controversies of whether stage 2 labor results in airborne droplets that the baby could be exposed to in the delivery room. We know that the virus has been cultured in the urine and in the stool, and these are things that are all potentially in contact during at least a vaginal delivery process. There's the potential for droplet contact if the baby is put skin to skin on a mom's bare breast immediately after delivery. And then even after delivery, there's still the question of in the mother's room, whether this baby is going to be exposed to airborne or droplet virus during routine cares. And so it really underscores that the peripartum and postpartum care are probably the higher risk areas with respect to these babies being colonized with this virus and potentially getting sick. To address that, we have developed a couple of different educational handouts at Stanford and have developed workflows, whereas a normal healthy delivery would not necessarily result in a prenatal consult. If the mom is known to be infected with the virus, we have a flyer that we give them to explain our processes for how we're going to do certain modifications that I've described, as well as care to help educate them about the care of their infant to protect their baby after delivery. So after delivery, we're asking that moms basically clean up, regown, try and get as clean as they can, and don a mask for when they're going to have interactions with their child. Moms who don't require airborne generating procedures, meaning those who are minimally symptomatic, don't need respiratory treatments, for example, can be placed in single patient rooms. PPE, again, is controversial, and so I'm just going to defer to individual institutional guidance, different degrees. Again, it's thought to be a droplet pathogen, not an airborne pathogen, but some are taking higher precautions. And then where the labor support person goes really depends on the shared decision making that we have for the newborn infant. So if the baby doesn't require NICU care, there's really 3 different possibilities for where these babies can go. The first is the usual mother-baby couplet care, which is co-location. But in the setting of a mom who is known to be infected with the virus, there are recommendations from the American Academy of Pediatrics and the CDC endorsing having the baby placed at least 6 feet from the mom's bed and separated through a curtain or possibly an incubator or both. There's also the possibility of separating mom and baby, which again is very controversial. In our institution, what we've asked is that if the labor support person, if the baby's going to be separated, we do allow the labor support person to stay with the infant, but also donning PPE, knowing that they're a direct contact and at some point may be an infectious risk. We also ask that labor support person not go back and forth between the baby's room and the mom's room to minimize the risk of cross-contamination. There's also the possibility of cohorting these infants. Again, it means separation, but perhaps not in a separate private room for the baby. And that may be necessary based on staffing or room availability at your institution. And these choices, I'll just mention, these choices can be perceived differently by families depending on their level of risk tolerance or risk aversion as it relates to this pandemic. And that may be influenced by what mom's signs and symptoms are of her illness. Is she asymptomatic, or is she actually very symptomatic from a respiratory standpoint? And so we've kind of come full circle with respect to how we approach these conversations. We initially started out following the CDC guidance, which was a bit more directive and talked about somewhat advocating for the separation of baby from mom, but the ability for them to be co-located depending on institutional constraints. And this was somewhat different from guidance issued by the World Health Organization, which was a little bit more liberal and encouraged breastfeeding and co-location using PPE precautions. And so we started by initially recommending separation. Then we got into an era where we had to think a little bit pragmatically, because if we were actually able to separate moms and babies, we would potentially run out of postpartum rooms because we would need twice as many since they're not doing couplet care. And now we're in an era of what we try to do is shared decision making, where we're educating and counseling parents, letting them reflect and think about their concerns about their baby, and balancing that with obviously a desire for family-centered care. And at the same time, let's see, can you see this? There we go. Yesterday, the CDC, kind of backtracked on their recommendations and are still kind of putting out a statement for a primary recommendation to separate mom and baby to prevent horizontal transmission, rather than having more neutral language. They still do allow for co-location, again, trying to allow individual institutions to do their own troubleshooting depending on what their constraints are. And I think the reason they have kind of come back to this primary issuance of recommending separation is, as you guys have probably seen in the media, there's emerging data about whether this virus can cause serious infections in infants and children. If the baby requires neonatal ICU care, there are some important distinctions to draw as it relates to the CDC guidance. For adults who are infected with the virus or considered PUIs, there are statements to say avoiding non-invasive ventilation and performing aggressive early intubation to optimally support patients with COVID-19 and to minimize the risk for healthcare workers. And so again, if these babies are considered PUIs or potentially infected by virtue of their mother's status, the question is, how do we manage these babies? Because we have to wrestle that with the fact that in newborn ICU care, non-invasive respiratory support really is a mainstay of therapy to treat our premature infants with respiratory disease. And as you know, many of these premature infants are going to have respiratory symptoms. That's not necessarily because their moms had COVID-19, but more likely because they're premature and have surfactant deficiency. But at the same time, the clinical profile of COVID-19 in infants is emerging, and the risks to healthcare workers are unclear. And so again, we have to use every precaution until we know more. And so what we do is for those infants who are requiring airborne generating procedures such as high flow cannula, CPAP, or intubation, we are placing them in airborne isolation, even though perhaps maybe their risk isn't that high to us. But we have a duty to protect our healthcare workers. For infants who don't need respiratory support, we are in discussion with our infectious disease specialists. We do place them in droplet precautions, which can be in a private or semi-private room. We are using an incubator for just an additional level of protection, as we would in our newborn nursery too, to protect the infant from, even healthcare workers who might be asymptomatically infected, but also in the reverse instance. We do avoid paired assignments just to ensure that the nurses have the bandwidth to adhere to PPE precautions and also to minimize cross-contamination to infants for whom there isn't concern about COVID-19. Visitation is always a challenge. The NICU is a protected environment. These are by definition immunocompromised. Their white blood cells don't work. Their immune systems are very immature, and they are at risk for overwhelming infections. And therefore, if a mom is infected, she is not able to visit until she has done her required quarantine period and is asymptomatic. And we do the same for fathers for the same reason, assuming that even if they might test negative immediately, that they have the potential to convert and be positive. And we want to make sure we don't have that kind of a Trojan horse, so to speak, entering our unit and potentially exposing our healthcare workers and other and the environment and other children. We're also in an era where in our hospital, we're doing single parent visitation, meaning mom and dad don't get to visit the bedside at the same time, which is very challenging when you have a brand newborn, you've just started your family, and really the whole point was you're a family now, but you can't actually be a family in the hospital as it currently stands. And that's just because we need to minimize exposure risk to our healthcare workers, to the environment. Many NICUs are still built as open bay NICUs where things can get crowded very quickly. And so what that's prompted us to do is rapidly deploy televisitation. I think that's a little bit different than telehealth, which again is something that we've entered into for people to do consults without having to physically be with their healthcare provider. The internet accessible remote viewing cameras have been available for about 5 years, but NICUs have been really slow to adopt it. And there's a lot of IS and OSHPD considerations, and so now the most rapid means of deploying televisitation is through the use of tablets. However, the challenge is many of these tablets are produced in China, and so there are backlogs in production as a result. So I'm sure Apple and anyone who makes tablets was suddenly seeing a demand from hospitals so that they could allow televisitation by parents. Breastfeeding is also a question as it relates to infectious risks to the baby. As we talked about, virus has not been documented in breast milk so far, and therefore breast milk in and of itself is considered safe. However, the act of breastfeeding might constitute a risk for horizontal transmission. And so, perhaps, again, depending on the parent's risk tolerance, expressed breast milk might be the safest way to nourish their child. If a mom chooses direct breastfeeding, she obviously is recommended to wear PPE, and her decision to do one or the other is, again, through education and shared decision making. Testing of the baby is generally reserved for those born to confirmed mothers as opposed to those who are still a PUI at the time of delivery. The AAP and Section of Neonatal Perinatal Medicine has recommended doing nasopharyngeal, throat, and if available, rectal swabs at 24 and 48 hours of life. Again, these recommendations are constantly in evolution. So at Stanford, what we've decided to do, rather than making recommendations and issuing changes on a frequent basis, we are simply just involving our PSID team to guide us on what to do. I'm going to talk a little bit about COVID-19 infection in the neonate. Again, we've really thought that children were the asymptomatic carriers, if anything, propagators of the virus. Initial case reports indicated that overall in the pediatric population, COVID-19 resulted in mild disease. However, this publication, I think this is about 2,000 children in China, indicated that even though the overall rates of severe illness is overall quite low, if you look over in the column of severe and critical, the highest rates of severe and critical illness occur in children less than 1 year of age. Our experience with COVID-19 infection in newborns is rapidly emerging and currently amounts to small case reports in series. The majority so far have concluded that likely the route of transmission was through horizontal contact and not vertical. This is a case report from a few weeks ago about a 3-week-old former 36-week infant who presented with respiratory symptoms and hypothermia and did require intubation, had a pneumothorax and chest tube placement, but did recover and was home after about a week. And again, these little things just keep popping up, and we're still trying to learn as much as we can from this. And so to that end, a bunch of different organizations have put together registries. The Vermont-Oxford Network is doing a point prevalence audit. The Section on Neonatal Perinatal Medicine has rapidly deployed a registry to report the results of babies born to COVID-positive moms. I believe there's a similar one in the UK. At UCSF, there is something called the Priority Study, and this is to understand pregnancy outcomes for moms infected with COVID-19 during their pregnancy. I think that's going to be really interesting to understand the impact of this infection, not only at the time of birth, but in the first and second trimesters as well. And then some investigators in Colorado have put together what they call the NeoClear registry, and this is really an aggregation of every case report, every case series, so that people have a single source of information. It's effectively a literature search done for you, so with a brief synopsis of what the results were, so that you can keep yourself up to date. I'll just share what is publicly available from the Section on Neonatal Perinatal Registry about infants born to COVID-19 positive moms so far. It's all very preliminary, unscrubbed data. Some of these numbers so far don't totally add up, but they're trying to do this, sort of rapid deployment of data just in the interest of transparency and really as a way to thank the people who have quickly gotten IRB approval to submit data. So they have information on 304 mother-infant dyads. You can see 230 were COVID-19 positive. The vast majority of them were asymptomatic, which is quite interesting. As we know, that's how we think this virus has propagated through the population is through these asymptomatic carriers. We have, this is where some of the data get a little bit interesting. If you look under isolation and locations of care, about half of these infants were rooming in with their mothers. Again, we talked about that shared decision-making dynamic, but that might also reflect certain contingencies of the institution. Most were in some sort of isolation precaution, though differing degrees depending on institutional experience and recommendations. Most babies had no respiratory symptoms and did not require any respiratory support. And of those who did have respiratory symptoms or required support, I don't think we have clarity about what those underlying reasons were and whether that was related to infection or other reasons around delivery. This talks about how infants have been fed, and you can see direct nursing happens in a little bit over a third, but we also have a fair number of people doing express breast milk fed by mom or by another person. And then, really it's interesting because we can take all these precautions and separate moms from babies in the hospital, but ultimately, especially if they're a well infant, they're going to go home in 2 days. And so it's important to educate your families about how to minimize the risks of horizontal transmission at home. And we've had a similar education document prepared to help educate families to keep their babies safe. I think the bottom line is we're really in an unprecedented time where there's concern about large prevalence of infection and perhaps insufficient resources to keep these babies safe. We can't necessarily provide alternate housing for these moms from their baby to keep them safe. Different areas of the country have different prevalences of single family homes or multi-generational homes, and what this means for the risk for the baby is really challenging, and the question of whether you send them home with PPE. We talked a little bit about visitation policies. Again, this presents some challenges in providing family-centered care. Most of our adult hospitals here in California are not allowing any visitors, and so if you have a mom who has a significant pregnancy complication that requires delivery in an adult hospital, and the example here would be like a placenta accreta requiring a multi-specialty team, the father cannot be present at delivery, which is sad, but reflects the current climate that we have. Then there's other instances of when there's multiple gestation. If we say only a single parent can visit at any one time, if there's more than one baby, does that mean both parents get to visit? And so we're kind of having to figure this out as we go along. Other lessons learned is depending on your institution, you may be a NICU housed within an adult hospital where there's a desire for kind of consistent and comprehensive guidance about PPE. And sometimes that may or may not make sense for our NICU population. As I mentioned, many of our NICUs are older open bay style and not necessarily single private rooms that are predominant in an adult hospital. Again, the question of whether an incubator might help create a single patient room environment as a layer of protection is something that we're kind of falling back on. And then I've talked a little bit about these directives discouraging AGPs in the adult population, whereas that's the standard of care in our NICU. We've also had to do social distancing rounds, social distancing family care conferences, and it's really an interesting time to be working in the NICU and in newborn care. I think we're kind of running out of time, so I'm not really going to go over this too much about surge planning, but certainly there are contingencies for if you have an influx of infected moms. It does require some creative thinking about how you staff your unit and how you use non-MD providers. Fetal monitors can be used more creatively if you have a limited number and a lot of moms delivering. And then, I think the big question is, whether early discharge should be considered for these newborns, both to, if you are not born to a COVID positive mom, but you're concerned that you're in a COVID exposed type of environment, would you want your baby discharged early? Or because you've got surge capacity, do you need to discharge children and moms early to make rooms available? And so it's really challenging to get sort of the requisite screening done at 24 hours of age to accommodate these early discharges. And then there's challenges in the outpatient setting. Babies are typically supposed to be seen within 2 days of life for a weight and jaundice check. And that has implications, again, as far as risks to the baby being brought back into the healthcare environment. And so just to summarize, hopefully these slides have shown that COVID-19 has had a real impact on how we manage expectant moms and newborns. We have very limited data, and we're currently having to use that along with our best judgment and our obligation to protect our patients to drive real-time decisions about clinical care guidelines. I still think we have more questions than answers right now, but I think as we're learning more, the balance of that is beginning to shift. And then just for a moment to finish with some levity, this is what I drew as my learning curve for managing COVID-19 and kind of overlaid it with, I think it's the stages of grief. I started with denial, thinking COVID-19 was just an adult disease. Obviously had to come to the realization that babies are actually born from adult mothers who could be infected. You know, I went through the bargaining phase of how we had to work in teams to rapidly develop policies and understand different priorities for family-centered care versus strict isolation precautions. You know, I'm somewhere between my depression and acceptance phase as we have to continually readjust our policies as we learn more, and to be resilient and just understand that this is the new normal as far as how we approach and we're doing this for one pandemic, but I think we're learning that perhaps there's another one around the corner, and we've all learned a lot in how we've had to rapidly make decisions on behalf of moms and babies.
Well, thank you, Dr. Davis, for such an informative lecture. And I think that the last graph, I think, can be used for anything that we are learning about this new disease, in which it's just this decision-making tree through the time that is very, very informative. So again, thank you very much. You got your audience all the way through until now. And I have many questions, and I would like to summarize some of them for you, understanding that the knowledge is being built, and probably we don't have the full data about that, but we would like to know your opinion, your honest opinion about these issues. So one of the questions is, mothers tested, how many days before has been swab done to a mother? I think that this refers to what would be your schedule of testing the mother prior to delivery.
Yeah, you know, as you know, just because you're negative one day doesn't mean you're going to be negative the next day. So I think that's really important. We're typically bringing these moms in, you know, we have a limited number of rapid testing kits, and then we've got our standard RT-PCR that they can actually do in high volume with reasonably good turnaround time, usually about 12 hours. So we're trying to balance the limited availability of those rapid turnaround kits, which is about 90 minutes. So for the moms for whom we can predict which day they're going to come in, we're bringing them in a day or two early to swab them so that the results are known when they do come in. And so it's, you know, typically 48 to 72 hours beforehand. And we're reserving those rapid kits for the moms who, you know, don't have an induction date and present in labor, and you need those answers pretty quickly to guide your management during the intrapartum course.
Okay. There's a logistic question here, which is, if no skin to skin with the infectious mother is recommended, how about skin to skin with the support person? Is the support person also recommended to get tested before delivery if possible?
Yeah, we also have kind of, we had a conversation where we ended where we started as far as how do how do we know, is there a way we should try and know what that partner's status is? We currently haven't figured out a workflow to test the labor support person since they're not a patient of the hospital. They can go somewhere at their own expense and potentially get tested. And sometimes they may choose to do that for their own sense of security and peace of mind. If the baby is co-located with mom, then that labor support person is recommended to wear PPE, again, because they're still in the same environment as mom and potentially exposed to droplets. Again, if we don't know that partner's status and they've decided to stay in a separate room with the baby, I think we are still trying to figure out in real time how we manage those individual circumstances as far as that partner's status on that particular day.
Okay, thank you. There is another question regarding the searching of the mother. I think that you already answered that, but the question is whether the expectant mothers now in office prior to delivery rate, did you test them? I mean, do you know if they test them prior to go actually to the hospital?
Yes. Again, if they have a scheduled date, we are testing them. I think some OB practices are testing moms. Sometimes the parents are asking for it just for their own peace of mind. Again, you want that testing as close to the time of delivery as possible. Otherwise, you're just going to have to repeat it. So, for example, if a mom is tested 2 weeks prior to delivery, say she goes in and is getting her GBS swab done and gets tested at that time, if she doesn't deliver for another 3 weeks, I don't think we know whether that negative test 3 weeks ago is really valid. And so we are testing them again.
Okay, thank you. Another question goes for the vertical transmission. And the question is, what shall we tell to our patients about the incidence of COVID vertical and horizontal transmission to the couple? What is your experience about that?
Yeah, I think from a vertical transmission standpoint, I'm really curious about the priority registry that is being set up at UCSF. As we know, with many viral infections, our classic teaching about torch infections is there's differential risk of vertical transmission depending on the pathogen and the time in pregnancy. And I think for this one, we really don't know. Does a symptomatic viremia in first trimester potentially impact that infant down the line? I think we'll have better answers to that in 6 to 9 months. I think again, if we borrow from influenza, which is a not dissimilar pathogen, I think the risk of vertical transmission is quite low, but I don't know that we can say it's zero. And from the risks of horizontal transmission, I think I would tell a parent that that is probably the greatest risk to the infant, and that we need to do everything we can to protect that baby. And that does sometimes mean some trade-offs in what we had envisioned for our delivery. And that's, I think, just an unfortunate reality that we have right now. The way I try and phrase it to my parents is we all have the same goals. You want a healthy baby, I want you to have a healthy baby, but we might have to understand that the trade-off for that is that what you would envision for your delivery might not actually be possible.
Thank you. There is now an interesting question about breastfeeding. And the question is, if the mom is COVID positive, can the breastfeeding area be sanitized and breastfeeding allowed? So it will be a possibility?
Yeah, and I think different institutions have approached this a little bit differently. Some say that the mom should wipe down her breast, for example, before putting the baby to breast. They should don a clean isolation gown, meaning take off whatever gown they might have had on in the hospital, a cloth gown, wipe everything down, don what would normally be an isolation gown so that everything is fresh and new. And again, I think different moms are going to have different levels of concern. Some aren't going to be as concerned, some are, and I think we need to adapt to whatever their own individual needs are, and give them the equipment that they need.
Wonderful. So as you can see, we are getting a very smart audience here. Look at this question. Did you have any case of positive IgG antibody in neonate from infected mother?
Mhm. I don't think we have started, well, at least here at Stanford, I don't think we have started doing antibody testing on the neonates. I think a lot of that is like all of these investigations are being rapidly deployed. Bonnie Maldonado is on the Red Book committee, and she has done a phenomenal job of trying to systematically study this rather than just kind of get information on the fly. So, you know, one, we don't have a lot of positive babies, and so therefore that limits our population to do antibody testing. And two, I think even with antibody testing, there's still a lot of questions about the test validity. I'm hearing things about maybe there's some false positives in those antibody tests. So, you know, everyone is doing their best to try and develop these technologies as quickly as possible, but we haven't had the time to really study the fidelity of them and understand how to interpret the results.
Right. No, I think that the point of this very smart question was about to you know, to somehow look for whether the baby can develop immunity while inside of the mother,
Right.
and if there is any data about that, or any, do you know anything about that they can be already developing an immune response intrautero?
Well, certainly, I think if we borrow from, you know, our teaching about other pathologies, we make an assumption, I think rightly so, that babies are able to acquire a lot of passive immunity from those moms, both before birth and also through breastfeeding. And again, that's why it's a real challenge, because we want those babies to get the breast milk, because we think that that potentially can help protect them from horizontal transmission risks. But I am not aware of anybody who's systematically drawn blood from newborns of infected moms to know if they've had positive IgG.
Okay, and I just want to leave you with the last question, because we have been taking a lot of time and effort from you. So the question is whether are you aware or you have seen any medical conditions from these newborns other than respiratory conditions from patients COVID-19 positive after delivery? Are you aware of any other high risk?
Yeah, I think there's been a few case reports, and frankly, we had one baby come in with fever and diarrhea symptoms, and as we know, that's thought to be maybe those were some of the underappreciated symptoms of this virus early on. So I do have suspicion that I had a baby come through my hospital who presented with fever and diarrhea, and at that time we had fairly rigid testing criteria, and because the baby did not have respiratory symptoms, we did not test that baby. I believe there are some case series that do describe infants testing positive after presenting with GI symptoms.
Okay. Well, I think that the time comes, and I just want to thank you again for your kind and very interesting presentation, and I hope that this was as useful for the audience as it has been for me. So thank you so much, Dr. Davis.
You're welcome. Thank you, everyone.